Hello and welcome to the 2023 Paramedic Protocol Update for Princeton Rescue Squad. As you will see, there have been a few protocols that have been added this year in comparison to previous editions of protocol, and there are several others that are included in this list that do not have any specific changes. However, the state does recommend that you refresh yourself on these to make sure that you're up to compliance with everything. So for this year on the initial treatment and universal patient care algorithm, there have been a few changes, of which include a change to the oxygen SpO2 percentage, and they have added a interfacility protocol in this to help to cover some of the gray areas that have not previously been well defined and questioned by myself and others. They finally have accepted the fact that COPD patients may not easily attain a greater than 94% pulse oximetry reading, so the protocol has been changed to reflect that for a COPD patient and a COPD patient only, we are to get the oxygen to 90%, whereas it used to be 94, and still is 94% for all the other non-COPD patients. The emphasis here is to remind you to properly expose your patient as needed and indicated. This is to prevent us from having missed injuries that might just be hid underneath clothing that would be otherwise noticeable upon proper exposure of the patient. This also is the start of the interfacility transport section of the new change that will be outlined in the next slide. Again, here is the interfacility transport section of the update, and I'm not going to go through and read all these bullet points. However, know that this is pretty much the way that things have always been. We're just now establishing it in a black and white format so that there'll be no questions. The change for 4112, the tranexamic acid optional protocol, they have changed from the 2022 guidelines to the 2023 guidelines, adding number 4 under section B, which outlines that adult and pediatric patients with acute traumatic brain injury who are within 3 hours of injury, that have a Glasgow score between 9 and 15, and are without major extracranial bleeding, are eligible and indicated to receive TXA treatment pre-hospital. Also, it is a reminder that if the patient is pregnant, this does require MCP order, and they will advise further. Also, they will help to outline where the patient needs to be taken, and they are reiterating the proper doses for loading dose and maintenance dose. New to the 2023 protocol is Protocol 4113, antibiotic administration for long bone fractures. This is indicated for patients with open long bone fractures or complete or partial amputation of an appendage or limb. The skin must be open in order for them to receive antibiotic therapy. It is contraindicated anytime that they have had an injury that is over 3 hours old, or if they have a known allergy to cephalosporins. This would also be contraindicated in any patient that you can't confirm whether or not that they have a cephalosporin allergy due to altered mental status or unconsciousness. For the dosage and administration, of course, for the pediatric populace, it is 35 milligrams per kilogram to a max of 2 grams. For the adult, less than 120 kilograms, it's 2 grams. And for the adult greater than 120 kilograms, the dose will be 3 grams. All of these diluted in 10 cc's of normal saline and administered over 3 to 5 minutes by slow IV push. For Protocol 4607, The thing that I want to remind you all about is that ketamine is still in the protocol. However, ketamine administration does require MCP order. It is no longer a standing order for paramedic providers. Also, pertaining to the ketamine administration, please note that they have changed the dosage. In the 22 protocol, it was 5 mg per kilogram if you did an IM to a max of 320. In the 23 protocols, that has been reduced to 4 milligrams per kilogram to a max dose of 300 milligrams. If they have an IV or IO in place, that has not changed. It is 2 milligrams per kilogram to a max of 200. And again, this is per MCP order only. For the gynecologic emergencies and obstetrical emergencies protocol number 4608, the change in nomenclature and the point of emphasis here is that after the baby has been delivered, before we have cut and clamped and separated them from the placenta, we do not want to hold the baby above the placenta until the cord is clamped. We want to try to keep as much blood in the baby instead of it being all in the placenta. And just because we never use this until we have the opportunity to deliver a child, and most of us, myself included, have a hard time remembering this, please take advantage to review the APGAR scores and refresh that in the back of your mind. Also new to the 2023 protocol is an actual protocol for adult suspected abuse and neglect. Now, as you all know, we do have an existing one for pediatrics, but they now have one that is established for adults. This is to be a reminder, we are mandated reporters for all ages, regardless, for any suspected abuse or neglect. Those need to be notified to the charge nurse that you hand report off to at the receiving facility, and you also are responsible for making sure that the APS hotline has been notified and that the appropriate form has been faxed and sent to the local DHHR office. For the Morgan-Lenz protocol, the change here from the existing to the new protocol is to actually outline the indications for when a Morgan-Lenz is supposed to be used. And these do include chemical or thermal burns if they have a foreign body sensation with no visible foreign body, and to remove non-embedded foreign materials. Also new to the 2023 protocol is this update to protocol number 8301, the non-invasive ventilation protocol. Traditionally, this has been for CPAP only in the pre-hospital setting. However, new with the 23 outline, we now have the ability to utilize BiPAP for those that need it, that CPAP is not doing exactly what we need it to do for them. For BiPAP administration in the pre-hospital setting, it is to be a reminder that the same indications and contraindications exist for utilization of CPAP as well as BiPAP. It is a reminder also that these folks should have an end-tidal nasal cannula placed on them before you place the mask of the FlowSafe device on the patient, and that we should set our settings on the FlowSafe BiPAP unit to a setting of 10 over 5 to a max of 15 over 8 in the pre-hospital setting, and this is increased in steps of 2 centimeters of water every 10 minutes until you reach the max protocol or until the patient improves. I want to bring your attention to the notes at the bottom of this slide. While both CPAP and BiPAP can be used to treat the hypoxic respiratory failure, BiPAP is most effective for hypercapnic respiratory failure. So these are our folks that have the excess elevated CO2 levels. BiPAP is essentially interchangeable with indications for CPAP, but not vice versa. BiPAP should be continued until they are transferred to a BiPAP unit at the hospital. Also, as a reminder, BiPAP can be used on a DNR patient. It is not a contraindication. For Protocol 9101, Death in the Field, the change here uh, on this slide is that they want you to, if at all possible, make the contact for DNR orders by way of phone, not by use of the radio system. Also, in conjunction with the Office of Chief Medical Examiner, they have compiled this list of information that you should obtain before contacting the medical examiner's office to report your case. Also new to the 2023 protocol is for the life vest or the wearable cardioverter defibrillator. We have several of these that have been around in our community. Most of you have dealt with them at one point or another in time. However, this protocol will help to outline and kind of inform you on how the life vest works and what we may be called upon to do for the life vest patient. Also new to the 2023 protocol is the patient refusal guidelines protocol. Um, Refusals in the past have not been established in protocol. However, the state has compiled and put this list together to help make sure that everybody's able to dot their I's and cross their T's. They have helped to establish the who may refuse treatment, transport, and assessment, and outlining what a custodial parent is, who a minor is, and the stuff about emancipated minors, who guardians are. Here, I want to make point of emphasis about medical powers of attorney. If a patient is alert and oriented, has a GCS of 15, if they have an MPOA, the MPOA has no opinion. They can speak their opinion, but it's not an opinion that you have to honor. The only time that the medical power of attorney has the legal capacity to direct you upon patient care is if the patient is confused and or if they lack capacity to speak for themselves. The next thing is that letter D, patients that are under the age of 18 cannot refuse treatment. The parent or guardian must assume responsibility. So caretakers, school nurses, teachers, school officials, these folks are not considered guardians for refusal of care and treatment. A few special circumstances that I would like to review. If you have a patient that does not have the mental capacity to refuse care, and there's no one there that is authorized to refuse care on the patient's behalf, all reasonable steps to secure treatment and transport should be emphasized and taken without placing anyone in jeopardy. MCP should be involved in this process, and they may advise you to restrain and transport as necessary. If you have a combative or otherwise intolerable patient that does not want to follow directions, you may have to utilize law enforcement, fire department, and other EMS providers to help to assist to get the patient secured properly. If law enforcement has a suspect in custody and they're insisting upon asserting medical responsibility, EMS should contact MCP. EMS providers should also document the law enforcement's agency, the officer's name, and the badge number in your PCR. Under no circumstance should a patient be transported while they are handcuffed with their arms behind their back. If a patient is handcuffed, the cuffs must be moved to the front, and if at all possible, law enforcement should accompany the patient to the hospital in case something should decompensate en route and the patient have to be uncuffed for us to properly be able to treat the patient. As to what you see here at the bottom, this CRAM method, this is essentially what we've always done in obtaining a refusal. I just have a new mnemonic to help to dress this up for the people that don't do refusals the way we do here. Just because someone is alert and oriented times 4 does not automatically mean that they have capacity. Inversely, a patient that is disoriented doesn't always lack capacity to refuse treatment. Capacity can wax and wane, and it can be present at one day or one moment and gone the next. So every time that we go to encounter a patient, just because they're confused today doesn't mean that they'll be confused on the next trip. When a refusal is in the outcome of the patient encounter, you must have an appropriately signed medical form against medical advice. And just as a reminder, if at all possible, have someone else besides your partner witness the refusal for patient care. This could be a patient family member, this could be a friend, this could be the fire department, this could be law enforcement. This is someone that is neutral in the whole decision-making process of refusing patient care. The only time that it is acceptable for your partner to sign as a witness is if you have no one else there that can sign the refusal for you as a witness.